Hello everyone, my name is Dr. Michael Mamone. I'm an internal medicine resident with the Florida Atlantic University. I'll be presenting a case of cryptococcal meningitis in an immunocompetent male with no risk factors. My co-authors are Lila Tao and Dr. Catherine Riano. A little introduction of the case. So cryptococcal meningitis is caused by Cryptococcus neoformans. This is an encapsulated yeast and is typically found in bird droppings and soil, is entered via inhalation. There are roughly 200 new cases of cryptococcal meningitis each year, with a relatively high mortality rate of 20 to 30% in 1 year. And 85% of these cases are actually seen in those with HIV and AIDS, and is relatively seen in the immunocompetent individual. So a little bit about the case. A 63-year-old male. He has a past medical history of hypertension, diabetes, hyperlipidemia, presented to the hospital with altered mental status. The patient had been experiencing confusion, dizziness, ataxia, headaches, and fevers for the last 3 weeks. He denied any alcohol use, no smoking history, no significant family history, no recent travel. Surgical history consistent for partial colectomy in 2012, given history of colon cancer. On review of systems, the patient denied any fevers, night sweats, cough, burning on urination, and diarrhea. On his physical examination, the patient was disoriented and unable to follow any commands. However, he had no appreciable focal neurological deficits. His lab work was relatively non-revealing, with a CBC within normal limits, B12 folate was within normal limits, serum tox was negative, urine drug screening was negative. He underwent a CT scan of the chest, which showed a possible right lower lobe infiltrate, as well as CT and MRI of the brain, which was negative for anything acute. He was admitted to the hospital, underwent treatment for community-acquired pneumonia with Herceptin and azithromycin dual therapy. After roughly 2 to 3 days, he still had no significant improvement in his symptoms, and he underwent a lumbar puncture. The lumbar puncture came back positive for cryptococcal antigen with a titer of 1 to 160. His omic pressures were also elevated. India's ink stain was negative. He was tested for HIV, which was negative, and he had a CD4 count of 926. The patient was started on amphotericin B and flucytosine induction therapy, and then had dramatic improvement in his mental status after roughly 2 to 3 days. In the center of this screen, you'll see two figures. In figure 1, you'll see a beautiful picture of the Cryptococcus neoformans. They're creating a spherical yeast cell, and you have a nice polysaccharide capsule, which will appear as a halo around the cell wall. And then in figure 2, this is a case of cryptococcal meningitis, and you'll see some mild meningeal enhancement on the left and on the right, and these are MRI imaging. A little bit of a discussion about this case. So cryptococcal meningitis does have a subacute onset with fever, fatigue, headache, and neck stiffness. The diagnosis is typically done via isolation of the cryptococcal antigen in the CSF and serum using the latex agglutination or enzyme immunoassay. The yeast can also be cultured on a Sabouraud agar and gram stain using Indian ink stain, where you'll see those nice thick polysaccharide capsules with halos around the cell walls. Your imaging studies will complement the clinical exam, and CSF analysis in the diagnosis of cryptococcal meningitis, MRI brain, may or may not show the soap bubble lesions from gelatinous pseudocysts. Unfortunately, we do not see that in figure 2. Mortality rate in the immunocompetent patient is relatively high, and this has to do due to a delay in diagnosis. The first, if a patient presents with altered mental status, Cryptococcus neoformans is not high on my radar in an immunocompetent individual, and this is why this is most likely leads to delay in diagnosis. And as such, you'll see that they actually develop more severe complications, such as permanent neurological sequelae, focal cranial nerve abnormalities, blindness, deafness, and stroke. And this all has to do with delay in diagnosis and treatment. So recommendations for treating immunocompetent patients with cryptococcal meningitis include an induction therapy of amphotericin B with or without flucytosine for 2 to 4 weeks, followed by a step-down regimen of 400 to 800 milligrams of fluconazole per day for up to 12 months, depending on the patient's clinical response. This differs compared to the immunocompromised patient, where their induction therapy is typically done with dual therapy of amphotericin B with flucytosine. It's done with a dual therapy. So it's important that cultures are used to monitor response in immunocompetent patients, because the cryptococcal antigen testing does not correlate with CSF sterilization after 2 weeks or 180-day outcomes in HIV-negative patients based on previous studies. Thank you for listening to my presentation. My references are listed at the bottom right of the screen. Thank you.